Okay. So, like I said, just a couple of housekeeping things. First of all, the Canvas access has been kind of screwy for some people. I noticed that about 80% of the class got in with no problem. Um, for whatever reason, 20% of you guys, I'm not sure if it's like a setting issue that's making things different, but some of you have had to do some extra steps where like you clicked on the link, signed up for the class, it never once asked you for a password, and then the first time you try to log in, it expects you to have a password. So um, I've been working with some of you on that. Just stay patient with me. I know that everybody's worried about passing up due dates on their tests and all that stuff. I'm not going to hold you guys to the fire for um, due dates that are missed because of tech issues like that. That's something that we will continue to work on and get everybody squared away. Kedrick, I'm not sure if you're in the class. I know that we're currently working on yours, buddy. Just keep your head up. We'll get it. And anybody else, let me know. That being said, Canvas issues in particular, we have a couple of Canvas gurus in the class. So if, and by all means, reach out to me. But if you want, do it in the Facebook group. You can tag me in it. Those of you that are Canvas gurus, whether you're in the class right now or you catch the recording, help me out, because a lot of times I don't know how to fix the issue. I only know how to operate it just about the same level that everybody else does. So I'm not far ahead of y'all trying to fix these issues, but we'll get there. I did manage to figure out why y'all couldn't see your files. So the next time you log into Canvas, you'll be able to do that. And all of your assessments, like your individual skills, your trauma assessment, medical assessment, they're all there. You're really going to need those starting on the next module. We don't have to have them out yet because this module is all intro stuff. But keep that in mind, because when we're starting to go through those later chapters and we're talking about those assessments, I want you guys to be able to memorize them so that when you show up to boot camp, we're not still trying to get you to learn what's in your primary assessment, for example. I want you to be able to at least rattle it off. And then when we do the boot camp, you'll be able to get down into the here's how you're actually going to do the assessment and do the treatment and all that. So we spend more time actually getting you ready for what it's like outside of school. Let's see. Other than that, I did email everybody.
Hey, somebody need to mute their mic.
Yeah, I'm working on it. Sorry. Yeah, you guys, when you come in with your mic already muted. It's preaching to the choir at the moment, but it'll be in the recording. I did email everybody the schedule for the class, so you can see from September 1st that we've already passed all the way through to the end of the class in the boot camp, what days we're going to be meeting, which is important because there are some days that we're going to skip, being that we're going through some of the holidays and stuff like that. Google is having issues with sound. All right, give me a second. I don't know if you're having issues, you're not going to be able to hear me. All right. So anyway, not only does that show you what days we're going to be meeting so that you don't try to get in when we're not having a class on a holiday of some sort, but it will also show you when your modules are due. Remember what I was saying, each date has the class lecture, and I also put your chapter quizzes there with those dates as well. Doesn't necessarily mean that every chapter is due on that day, but that's where we expect you to be able to actually take that test. Some of you guys have flown through 9 chapters or whatever. You have access to all those. We don't advise you moving ahead just because we haven't gotten to those lectures yet, and it's reflected in how some are doing. Some of you guys are rocking it. Yeah, I can tell you guys already know a lot of the stuff, which is great. But try to stick with us. I know it's boring at the beginning, but we'll get through it. The other thing about the schedule that I sent out, if you look at each date, sometimes I'll have it where it just says read chapter 12. But you'll notice that there are some chapters where you're not supposed to read the whole thing because the chapter is way too huge. So we break it up. Like for this part, I want you just to read this page to this page. That's the only reason why, if anybody's using a book other than the exact 11th edition that we're using for this class, I know some of you had asked me to use a 10th edition you already had. Some of those pages may not line up properly for you. So kind of take that with a grain of salt. If we're talking about the GI tract and you're reading something about the nervous system, you know that the pages are different. You have to move to the right pages. But everybody else, all y'all were given links for the 11th edition, so you should be fine. Let's see. We talked about the quizzes, talked about the module exams. Like I said, make sure that even though your quizzes don't have to be done on that date, the module exam deadline is set in stone, short of something like, the guys down there with the hurricane issue. You guys will work on that. Okay, awesome. I'm glad y'all can hear me now. The only other thing I wanted to talk about, every module has a discussion question, and I'll look today. Some of you guys have already started replying to it, which is fantastic. But I just want to explain the guidelines for it. It's only 10% of your grade, but I want you to give one well thought out response of your own and then reply to two of your students. You obviously don't have to write a novel, but make it more than just a one sentence thing. And it's the discussion questions. They're in your Canvas. I did share where you can actually see the discussions link on your left-hand side now. So when you log back in, you may be able to see that. It wasn't there before. I'm not sure how a couple of your classmates got to those discussion questions early, but now you should be able to find them there. Let's see. Other than that, that's pretty much all of the housekeeping stuff for now. I will happily continue to answer questions as much as I can through email, Facebook group. Like I said, try to hit me in the Facebook group, because if I'm busy, one of your classmates may actually be able to answer it. And then that's fantastic, because you get the answer faster than waiting on me. But in the meantime, let's get on to chapter 3. All right, so like I said, tonight we're going to be talking about legal and ethical issues. So this is the kind of stuff that will keep you out of court, hopefully. And if you do get brought to court, knowing this and following these rules will keep you from getting sued or losing the lawsuit and that kind of thing. City one and responded to. Yes. So you're going to do your own response, and then just scroll through your classmates, and you can do it the first two you see. It really doesn't matter. You just read through a couple of them, get their points of view, and then give it a reply. They don't have to be novels. Just a few sentences at the minimum is fine. All right. So basic principle of emergency care is to do no further harm. Like we said last night, you guys are showing up to people, whether it's an emergency to you. It's definitely something that warranted them calling 911 for themselves. So we want to make sure as EMTs that we don't make it worse. One of the biggest concerns that we see about that, a lot of times you really see it more at the higher levels of paramedics, where they might give the wrong medication. Where it becomes a legal issue is when we're talking about, like, well, they gave the wrong medication because they didn't follow their protocols. They knew better. They tried to do something out of the box they shouldn't have. For example, and this is kind of an interesting one, because this is perfect. In this particular case, it was perfectly fine that he did it. However, it could have come back to bite him. There's a paramedic that I know that used nitro spray to relax the muscles in somebody's throat enough for them to stop choking on something. He knew exactly what he was doing. He knew what the side effects were going to be, and he knew it wasn't going to be dangerous for his patient. But if you take that knowledge and then you go do that to a 70-year-old heart patient with an unknown history, that could cause some massive issues if you should have done something different, like the Heimlich maneuver, for example. Healthcare provider usually avoids legal exposure if he or she acts in good faith and according to the appropriate standard of care. We did talk about your scope of practice a little bit on the last meeting. As long as you are doing what you're trained to do, how you're trained to do it, you guys will be fine. Just try not to. Sometimes you do have to kind of think outside the box. We will train you, we'll teach you some things that you can do that aren't necessarily put in your school, but they are perfectly safe. They're legal to do. They're just extra stuff. You're going to learn that kind of thing in our class. But like I said, be careful when you start really thinking outside the box and doing too much. nitro, for example, is a smooth muscle relaxer. So that's why he did it. He knew it was going to open up the guy's throat a little bit and that object was going to fall through. But also knowing what else nitro does could be cause for you not to do that. Emergency medical care or immediate care or treatment is often provided by an EMT. Obviously, you guys may be the first ones on scene short of an EMR. You're the first one that they see. You're the one that gets them when they're the most unstable. And a lot of times it's not as easy as if you were to just take a stable patient from somebody else. Let's see. Sorry to interrupt, but can you fill Pascal in on the discussion question? Yeah, okay. Sorry, guys. I'm going to go back on this one real quick. So your discussion question, basically, there's going to be one per module, and it has to do with that module. So if you see one that doesn't make any sense for what we've been talking about, you can save that one for later. But it's in Canvas. It's kind of mixed in with your quizzes. Each of you has to fill one, answer thoughtfully yourself, and then give two decent replies to your classmates. You don't have to write a novel. I'm not expecting you guys to write a book or anything like that. Just a few sentences, something to show that you actually read and thought about what we're asking about. Those discussion questions are mainly to get you to think beyond what's black and white in your textbook. So that will help set you up for how you handle your career, how you handle boot camp. You'll start to see through those discussion questions how you're going to go from the strict lab classroom stuff of this course to the real world, because everybody talks about how EMT school is not like the real world, and it really isn't. Those discussion questions kind of help keep you thinking outside those lines. And the discussion questions, if y'all have questions about that, by all means hit me up on the Facebook group and we'll talk about it some more. But some of your classmates have already answered, so I can tell that, and they were pretty good. They weren't too long, but they weren't like one sentence answers either. All right, so even when emergency medical care is perfectly rendered, there will be times where you might be sued by a patient seeking monetary compensation. Sometimes you're just a target. Hopefully that doesn't happen to you, but sometimes it does. So as long as you do what you're supposed to do, typically, even if you do get sued, you're probably going to win. So if anybody is not muted, go ahead and make sure that you mute your mic. I don't hear anybody, but just in case. Yeah, a book way and a real life way. All right, so let's talk about consent. We're going to start with that because we can't do anything legally if we don't have that, right? And now that is consent to operate on your patient. That's consent to not operate on your patient. It's all up to them. So consent is permission to render the care. If you show up to somebody and they have an issue that may or may not be an emergency, even if they called you themselves to come and help them, you need to get consent. There's a couple of different ways we get it, but it has to be done one way or the other. So the person must give it, and there's going to be some times where we'll talk about in a little bit where they may not be able to give you consent. Real quick, somebody not in their right mind, for example, if they're highly intoxicated or they got hit in the head, diabetic emergency, their blood sugar is out of whack, they can't really tell you no at that point. So they operate on a certain kind of consent. If the patient is conscious and rational, though, where they are awake and they know who they are, where they are, when they are, they do have the right to refuse care. Again, even if they are the ones that called you. Sometimes I've had elderly people call us out, complaining of stomach pains or a headache or whatever. We get there, they want us to check their vitals. They talk to us for a little bit, and then they refuse all care beyond that. They really didn't want to go to the hospital. They just wanted somebody to talk to and somebody to come out and check their vitals, which is, it's perfectly fine. You just want to make sure that you don't let that bog your system down. For a while there, I worked on an ambulance, and we did it proactively. We actually went without being called. We would just go and knock on the door and say, hey, just, seeing how you're doing, make sure everything's okay. Mainly to the frequent flyers, so that we give them the visits on our time, and when we know that we're able to do it without having to sacrifice a response to an actual emergency, as opposed to waiting for them to call us and then 5 minutes into that, we find out that we just missed an actual cardiac arrest or something like that. Anyway, back on the consent. So they have to be awake and conscious. They have to know, we always talk about it, we call it alert and oriented, and they have to be A&O, alert and oriented, times 3. They have to know who they are, where they are, and when they are. It's not necessarily their names, because if you don't have their ID and you ask them what their name is, they could tell you it's Scooby-Doo, and I mean, that might actually be their name. So make sure that they're questions you can answer as well. Foundation of consent is a decision-making capacity, so they have to be able to understand what it is they're consenting to. They also have to be able to make an informed choice regarding medical care. Even if it's not in their best interest, they can still tell you no. Patient autonomy is the right of the patient to make decisions based on his or her health. So just remember that autonomy being that they alone control their decisions of what happens to them. There are some exceptions to that. We'll get into powers of attorney later on, but on your average patient, whether they stubbed their toe or actually had some chest pains that might be legitimate cause for going to the hospital, they can still tell you no. We'll talk about some ways to try to convince them to go. So your first kind of consent that we want to talk about is express consent. This is the most common when you're dealing with a patient. This is where they actually tell you, yes, I want you to take care of me. All right. So they have to be, again, they have to be alert. They have to be able to tell you everything. They know where they are, when they are, and who they are. But they're actually awake enough to tell you either yes or no. So informed consent is valid if given orally. They don't have to write anything down. They can just say, yes, I want you to fix my leg or fix my arm or make my chest stop hurting, that kind of thing. To be valid, the patient must provide informed consent. So in other words, if you're going to try to work on somebody and you in yours as an EMT, you're going to know what you need to do to fix whatever it is that they're complaining about, but they may not. Somebody just may say, my stomach hurts. And they have no idea what to do to fix it, because if they did, they probably wouldn't have called 911. So they want you to help them, but there may be something in that care plan that you're going to do that they don't want. For example, I would rather take a bullet than a catheter. That's just me. If I ever need one of those things, I need to be out, completely out, or just take me out back and shoot me. I'll be fine with that too. But that's part of the care plan. So if I'm in a car accident and I need some long-term care, I'm going to obviously consent to it. But but I want to know if that's going to be a part of it. So keep that in mind too. If you're going to sit there, you're going to tell them you want to take care of them, you're going to give them some medication or something like that, make sure you say it out loud. Tell them exactly what you're going to do, and let them know that, so they know what they're consenting to. Implied consent. This is for the patients who aren't able to tell you. So if you show up to somebody who's already knocked out, say they're in cardiac arrest or something like that, or it's a diabetic emergency, because that's a big altered mental status issue where they're unconscious. They can't actually say, yes, help me. So we operate under implied consent. Basically, that's saying that if they were awake, they would have said, yes, they want help. Implied consent is only valid until they wake up. Once they're awake, they can tell you no, that they don't want any more help, and you'd have to stop. But in that unconscious period, it's implied that they would want your help. So implied consent should never be used unless there is a threat to life and limb. If let's say they're just drunk, they're passed out because they're drunk, or we'll go with something we can actually do in the field. So let's say that they overdose, or they knock themselves out on an opioid. All right, but their airway's not compromised. Some scared person just called 911 because they were asleep. They're somewhat drooling on themselves or whatever, but you can tell that as long as they stay in the bed, there's nothing wrong. In those cases, you can't. That's not implied consent, because there's no threat. So the principle of implied consent is known as the emergency doctrine. It's a good idea to get consent from a spouse or a relative. So if they are knocked out and the wife is standing there or the husband's standing there, you can go ahead and say, can can I give care to this, or do you have a problem if I do this treatment to them or something like that? So in those cases, in that example for Narcan, let's say that there's not an immediate threat to life, but you feel like you should give them some Narcan to kind of make sure that they don't go so far into their stupor that they do lose their airway. Because that's not implied consent, you can talk to the wife or something like that. That's okay. All right, involuntary consent. So this applies to patients who are mentally ill in a behavioral crisis, which also falls under mentally ill usually. Developmentally delayed. Basically, these are people who are at that particular moment or in general are not able to give consent for a reason that they will never be able to overcome, really. You obtain this consent from a guardian if it's a kid, or even if it's an adult, if they have a caretaker. Some mental illnesses, they do require, like they may be in a nursing home, a group home. They may have somebody that works with them on a daily basis and stuff, and then you're going to get your consent from them. So you kind of treat it like they are kids, in the sense that they don't really get the opportunity to tell you yes or no. You're going to get it from their guardian. If you can't get consent from the guardian, I will go so far as to say you may want to go ahead and operate on implied consent, which is perfectly fine if it's an emergency, but check with your state protocols. National Registry does say that you can use implied consent. We refer to that more when we're talking about kids, but the same thing applies here. All right, so for minors, the parent or the legal guardian gives consent. So if you show up and there's a 10-year-old that has really busted up his knee learning how to ride a bike or something like that, the kid can't tell you yes or no. It has to come from the parent, if at all possible. In some states, a minor can give or give consent, and in some situations, minors can give consent. We'll talk about those here in just a second. So depending on age and maturity, some states will say that if you're 15, 16 years old, you can give consent, even though you are still a minor. Emancipated minors, so if they're married, if they join the armed forces, if they're parents, then they become adults. So for example, if you show up and there's a 16-year-old girl who has a baby, under normal circumstances, as a 16-year-old, you'd have to talk to the parents, right? Because she's a minor. But because she herself is a parent, the courts basically automatically give her emancipation, because she has to be able to make the decisions for her baby, and she can't do that if she herself is considered a minor. So in those cases, you throw the minor rules out, and you just go ahead and get her consent. Just something to think about. Teachers and school officials may act in place of parents. A lot of times, like, I got 2 kids, we put them in school. I have to give a consent card that has information about where I've signed off saying that they can make decisions for me. If they can't, if it's something else, who can pick them up, all that stuff. So that information is used if the ambulance ever has to go back out there. All right, if it's a true emergency and no consent is available, you treat the patient and consider it as implied consent. Because again, if it's a major threat, you can basically imply that the parents would say yes if they were there to do so. No real parent is going to say, no, let my child die. I don't think anybody would want to do that. So you can basically say, and it'll stand up in court, that, hey, this was a real emergency, and so we went ahead and gave it. Forcible restraints. These are necessary with the patient who is in need of medical treatment and transportation, but is combative. Sometimes it can present a major significant risk of danger to yourself or others. There's a definite way to put restraints on. So we'll go about that. We'll talk about that at the boot camp. I'm not going to go into the how-tos tonight. But there's a right way, and then there's a definite wrong way, because you can actually hurt your patient if you put them on wrong, or even go so far as to kill them if you put it on wrong. So be careful with that. Whether or not you can do it outside of this class, it just depends on who you work for. The MidControl over your particular agency is going to dictate whether or not you can put on restraints, and if you can, to what extent, how to do it, and that kind of thing. But I'm going to go ahead and tell you, like, one big no-no is don't tie your patient to the ambulance. All right, you can restrain them to the stretcher, that's okay, but think about it like this: if you restrain your patient to the actual truck, like, or, you know, like one of the handrails or something like that, and then you wreck, or your ambulance catches on fire, you're going to waste valuable time trying to unrestrain your patient just to get him out of the truck. So restrain him to something that can move with him. Like you see in the picture, he's restrained to his stretcher. That's okay. If your agency allows you to do restraints, that's usually where we like to do it, because if something like that happens, all you have to do is just move the litter out of the truck, and he's still restrained and getting out of it with you. I know that a lot of places will try to say let law enforcement do it. Their idea of restraining and medical restraining are two different things. Sometimes letting them do it is fine. Just depends on what you're dealing with. Sometimes the law enforcement way of restraining a patient isn't really conducive to why you're doing it in the first place. All right. Forcible restraints, again, know your local laws. It's hard for us to talk about restraints in class because every one of you is going to have a different set of rules. Basically, it just depends on where you work. If you do use restraints, though, you got to make sure that your patient's airway is intact at all times, because they may not be able to, with the limited motion and everything, they may not be able to take care of that themselves, especially if you restrain them in a way that they say, for example, they can't sit up or something like that. And then so monitor your patient's respiratory status. If you restrain them, you are now in charge of their ABCs, even though they're awake, because they may not be able to do it on their own. All right, so the right to refuse treatment. Everybody has this right. Every conscious, alert adult with decision-making capacity can tell you no, and it pretty much doesn't matter what the reason is. You may be sitting there thinking that your patient's going to die in 10 minutes if they don't go to the hospital, but they can still tell you no. We have to sometimes get a little creative in how we convince them not to say no. But they do have the right to refuse, and they can withdraw from treatment at any time. So again, an example is, if, like I said, if I need help and I give you consent to treat me, and then if I'm still awake when you go to, if I see somebody pull out a catheter, I'm going to scream no. It's not going to happen. You just wait for me to go unconscious, and then you do whatever you need to do, but not while I'm awake to see it. And your patients have that right. You could be 90% of the way to the hospital, and then they can tell you they don't want to be treated anymore. So these kind of patients kind of present you with a dilemma, right? Should you provide care against their will, or should you leave them alone? Sometimes you may be stuck between a rock and a hard place. One of the biggest fallbacks that we're ever going to tell you in EMT school is called MidControl, but even that doesn't necessarily save you, because you may call the doc and tell them that you've got a cardiac patient. The doc's like, get him here. I don't care what you have to do. You still have to follow the law. So that part sucks. Calls involving refusal of treatment are commonly litigated in EMS and require you to proceed very cautiously. If you've never seen a refusal form that the patient signs whenever they say they don't want to go to the hospital, it's a very long, drawn out, a lot of words on the page that they're signing, basically saying, like, yes, AMA, against medical advice. They're basically saying that they understand what happened to them. They understand what needs to be done for their treatment. They understand what can be done, what can happen if they don't get this treatment, and they still want to say no. They have to sign on all of that, because otherwise they can show up to court and be like, well, I didn't know it was that serious. And there's no documentation saying otherwise. So as far as that goes, you must be familiar with local policies regarding refusal of care. Just keep in mind, almost every policy has a form for that. Most of them just use a standard form now. It's not even one that they wrote up on their own. But you'd be hard pressed to find an agency that doesn't want you to get an AMA filled out. And even then, the AMA usually requires a patient signature, your signature, and a witness, just to make sure that nobody can say that it was done after the fact or whatever. All right. Involve online medical control and document this consultation. So if it's a legit emergency, you can always contact MedControl and let them be the ones to make the decision. If they say get him here, I don't care what you do, and you go through with that, I'm not going to say that you won't be held responsible, because sometimes, a hotshot lawyer or somebody can win pretty much anything. But usually what's happening is the med director is putting that liability on himself. So there's that, because he's there. If he's that hell bent on getting somebody into the hospital, it's for a real reason that he's pretty sure would stand up in court if it ever went to it. But you can't. I mean, you can't just kidnap somebody either. So you try your best. You can get the police to try to talk them into it, even though they hate doing that. Um, if it needs to be done, do your best. If they just flat out refuse, you're like, all right, well, I may see you in 15 minutes when you pass out, and then I get your implied consent, and you're going to go to the hospital. Providing treatment is a much more defensible position than failing to treat a patient. If you needed to treat a patient and you just decided not to, that's neglect. If you start to treat a patient and then you decide you're done and you're the one that decides to just stop trying, that's called abandonment. So we'll get more into those here in a little bit in the next few slides. But yeah, if at all possible, try to get, especially in a real emergency, try to find a way to give them that treatment. Sometimes they won't do AMA because insurance won't pay for it. You mean the patient won't do an AMA or the agency? The patient won't sign. Right. Well, I mean, but that's the thing though. And we've had these patients who are like, I don't want to sign an AMA. I'm like, well, that means it's either get in the truck or sign this piece of paper. Like, we can't force you in the truck, but you got to pick one. And there are ways to get around that. If you're just in a stalemate, you can pretty much put in that the patient refused to sign, but you're going to have witnesses again saying, yes, he refused, he didn't want to sign. That way, if it does go to court, um, it'll actually stand up. And the scary thing is that those are typically the ones that are the highest probability of trying to take you to court. Just because, I mean, for various reasons. So, who can sign a refusal? A patient, parent, or a caregiver's decision to accept or refuse treatment should be based on information that you provide. You have to assess your assessment of what might be wrong. You have to tell your patient that. You have to describe what treatment you feel is necessary. Again, like I said, I'll let you do a whole lot of stuff to me, but when it comes to a catheter, just wait for me to pass out. I don't want to be awake for that. Any possible risks of the treatment, they need to know. The availability of alternative treatments, because some people may be wanting you to treat them, but not in the normal way. And then possible consequences of refusing. They have to be knowledgeable of all of that before they can refuse. Let's see what we got here. You have to witness for the bus. All this. Yeah, the fire department can do it. It's just somebody other than you and your partner. Let's see, I had a patient about 4 years ago that was in his 70s. His daughter was power of attorney, but did not have the proper paperwork, and he refused. We didn't take him, but I was never given a straight answer on if she still had power or not. Good question. We're going to get into kind of that a little bit here. So the issue with legal documentation like that, and we'll talk about what a power of attorney is in a little bit. If they don't have it in front of them, it doesn't exist in your eyes, especially when you're talking about things like a DNR. You have to be able to see it. It has to still be in date. I've given power of attorney to people before I've gone on deployments, and then I've turned them off. And this lady might have had it at one point, but if she can't show it to you, there's nothing saying that it wasn't nixed by the guy prior to that. So for your question, I would say it doesn't matter if she was legitimately having it or not. If she couldn't produce the paperwork, it didn't exist. Last night we had a patient refuse transport AMA for being hypoglycemic, so we stayed on scene and gave him glucagon, changed his levels before we left him. All right, so that's something else. Yeah, well, so when we get to, that's a good thing to bring up. Remind me when we go to the actual diabetes chapter. We'll talk about it here in a second, but also we can bring it up there. Hypoglycemia and hyperglycemia, if their sugar is way out of whack, they're considered altered mental status, at which point they cannot, they really can't refuse. All right, because they're going to fall under implied consent. So in your case, what y'all did, because a lot of people have hypoglycemic emergencies, and they're an emergency right there, but they're an emergency that can be completely fixed by the paramedic, which is what you guys did, and that's perfectly fine. You got there, you recognized that he was hypoglycemic, you gave him some glucagon, his liver dumped his glucose, got him back up to a good range, and at that point he's A&O times 3, and he can refuse, and that's what you want, right? You don't want to overload your ERs if possible. So in a lot of cases, you do want the refusal. It's not that you're not wanting to take the transport. It's just this isn't something that really needs to be transported. You could fix his sugar, get him to eat a sandwich, and he's going to be fine. Some people just let their, like, I forget to eat all the time, especially the last couple of weeks. I've been so busy. That you could do that. All right, so here in Alabama, you aren't allowed to give glucagon. Also, they can refuse even with implied consent. All right, so if you can't give glucagon, there's other things you can do. You can use oral glucose if they can maintain their airway. People give, amps D50, D20, D10, whatever. D40 for y'all. Okay. So there's other ways to do it. Yeah, some places don't like glucagon. I don't care for glucagon because if you're really hypoglycemic and your liver doesn't have any glucose in it anyway, the glucagon doesn't do anything. So you're kind of wasting your time and your medicine. But I don't know how somebody could refuse even with implied consent. I guess if they're able to, I don't know. I guess if they're able to refuse, then it wouldn't be implied consent. It would still be expressed. I'll look into that. Maybe some of you guys, the other guys that are in Alabama, can help expound on that to the class, or even to me. That's new. All right. So when treatment is refused, you must assess your patient's ability to make an informed decision. Again, so we're asking about their alert and oriented status. So they have to be able to answer you, right? If they're obviously an altered mental status, they can't refuse. I'm gonna put an asterisk on that because of the Alabama guys, but they have to be alert and they have to be oriented to a person, place, and time. So, and make these easy. All right, I forget what day it is all the time. So ask me what year it is or what month it is. You can always go with the president. That's an easy one for who, and then a place. Be like, where are you? Do you know where you're at right now? An example of when this is important. We had a guy had a seizure on the military base that I was at down in New Orleans about a year ago now, and we get there, he's already post-surgical, he's back on his feet talking to everybody, he seems perfectly fine. So we're expecting to be able to give this guy a refusal. Because he's a known seizure patient. He knew he had seizures. It wasn't anything new to him. So it's not like it was a true emergency. He came out of it, he's like, yeah, I'm sorry, I forgot my meds and all that stuff. So we're getting ready to get a refusal from him. We started asking him those basic questions. He knew who he was, he knew the president, but he thought he was at a hotel in like 1968 for whatever reason. He just had no idea that he was standing outside of the gate to the military base, um, and he didn't know what year it was. So, what do? I can't let him sign a refusal. He's not A&O times 3. There's actually something going on in his head that at that particular moment was still, it would make that legal document not hold up. So we went ahead and told him, like, look, we're going to take you to the hospital. It's right down the street. Hopefully you're in and out of there real quick, and then you'll be right back here doing what you were doing. But just to be sure. And we told him why. We're like, you're not at a hotel. It's not the 60s. It's 2019, and you're at a military base in New Orleans. So you can give glucagon in Alabama with the latest protocol update. Okay. For advanced and above. Yeah, the way to give glucagon is not something, the route that you give it is out of an EMT basic scope. So it usually is advanced and above. Let's see, before you leave a scene, a patient. Okay, I already talked about all that. Confidentiality. Now we're going to start getting into things like HIPAA. Anybody in here not heard of HIPAA at this point? So the fourth, you only have to be A&O times 3, person, place, and time. I've heard A&O times 4. but we don't teach it, not by curriculum. I don't even know what the fourth one would be. Help me out with that. What did they tell you? Unless are they counting alert as being one of them? Oh, okay. So yeah, that's just a verbiage difference. Um, when we say A&O times three, we mean the orientation is times three, and then plus your alertness on top of that. All right. Information should remain confidential between you and the patient, especially in regards to HIPAA. HIPAA is a massive punishment to you if you mess that up. In most states, records may be released by the patient, or may be released only if the patient signs for it, if a legal subpoena is presented, or if they're needed by the billing department. Because it costs like $80 to get a bag of saline these days, or something like that. So for HIPAA itself, this came around in the mid 90s, and this is basically saying that because we have built a system where a patient is going to go from the firefighter / EMR to the EMT, the paramedic, to the nurses and doctors, and then on to specialty care and so on and so on. There has to be a way to spread your health information around, but to only keep it to the people who need to know. So that's where that comes in. Anything that's identifiable, be it in any communication form, it could be on paper, it could be the way you talk about it, or anything. Everything that is specific to the patient is confidential. You can't talk about it to other people outside. You can mention anything you need to that's pertinent to, like, say, the nurse that you hand your patient off to, but only what's pertinent. An example of this would be if you took somebody in because they were in a car wreck and you're describing their the stuff you got from your assessment and everything. Well, let's say you found out in your assessment that they were diagnosed with, I don't know, we're going to say that they were found to have chlamydia or something like that. That is completely irrelevant to why you're working on that patient and what their treatment plan will be. So that is not something that needs to be said. Yeah, I know. Leave it to me. That's the first thing that came to mind. I was like, what would be an illness that has no role in a car wreck? But there you go. There's a Royism for you. This act, back to the actual HIPAA, it safeguards patient confidentiality, and it makes sure that you are only talking to the people that need to know, and you're only talking about the stuff that they need to know. So you can't go back to the station and talk about who it was that you responded to. You can't talk about any illnesses and diseases or even medications, because a lot of us in the field, we know what the medications are used for. All right, so if you tell me that somebody's on a certain antibiotic, and I'm like, I know why they're taking that, or something like that. Now I know too much about the patient. And you got to be careful about what you say. The fines are really, really, really steep. I know Oxford EMS had told my mother they weren't allowed to give glucagon. That's okay. HIPAA provides guidance on which type of information is protected, the responsibility of healthcare providers regarding that protection, and penalties for breaching that protection. And it can get up into the tens of thousands of dollars very easily when things are breached. And like I said, and that's not just loose lips. That's somebody's patient record being seen over your shoulder, something being left out on the counter without a privacy cover page on it or something like that. Something saved on the computer that somebody that doesn't need to have access to it has access. They may not have even opened it. If somebody goes in, healthcare IT is becoming bigger and bigger. There are people that will go into, like, say, a hospital and look at their IT systems and see if anybody has access to patient records that shouldn't. It doesn't even matter if that breach happened, if it is possible, if it's there. Whether or not it was actually accessed, that's a fine. They could get in trouble for that. So that's a whole other career field that's popped up. There are people whose career it is to just make sure that this folder with patient records in it is only accessible by the people that need it, and that they can see in the system that every other user in that hospital is locked out of that folder. HIPAA considers all patient information you obtain in the course of providing medical treatment to a patient to be protected health information, or PHI is what they call it. PHI includes medical information And this also includes any information that can be used to identify the patient. There may be certain situations where you are legally mandated to report your findings. Usually it's going to be things like child abuse, or where you're actually sitting in front of the judge and they're demanding that you say it. When you're compelled like that, you can do it, but otherwise, like I said, just be careful, especially for training. We go back, we take the calls that stand out to us, and we use those for training. You got to be careful about what you put in and what you take out. You can, by all means, talk about how the scene played out. You can talk about what you did with that car wreck. You can talk about, what this new medical situation was and how you treated it, how your assessment played out. All that is fine as long as you're not putting the actual patient's information into it. Failure to abide by the provisions of HIPAA can result in civil and/or criminal action against you. It just depends on to what extent you did it, and that can hit your agency or it can hit you personally. It just depends whether a couple of different things, and they'll find all that will come out in a court case, whether it was malicious or whether it was due to some fault with the company or whatever. All right, advanced directives. So we talked about this a little bit before. Some of it was mentioned, but we were going to wait till we got to these slides to really get into it. So an advanced directive is something that's in writing, that the person, while they were of sound mind, decided that they wanted it to play out this way in the event that they were not able to give this consent or denial at that particular moment. So there's a couple of them out there. The big one that everybody knows about is the DNR. DNR stands for Do Not Resuscitate. And this is a document that basically says if you show up to somebody's house and they're in cardiac arrest and they have a valid DNR, you don't work them. Okay. So 99% of the time, you won't work them. It doesn't mean don't treat. It just means don't resuscitate. And sometimes you may be able to do a whole lot of stuff because they're not technically in cardiac arrest. So, for example, you show up to somebody's house and they are not breathing, but they still have a pulse. You can breathe for them. You can give them rescue breaths. That's perfectly fine. They're unconscious from anything other than cardiac arrest. You can provide care. If it's a diabetic emergency, you can give them D10, D40, whatever your agency uses. Your paramedics can. You can give them not jack if they're knocked out, but you see what I'm saying? Like, treatment can happen to whatever level is there. The DNR won't stop it unless it's a resuscitation effort. If you're actually doing CPR, a DNR can and will stop you in those cases. So yes, you can breathe if they have a pulse, because all you're doing is providing rescue breaths. It's not necessarily resuscitation. That's been brought to court before because some people didn't understand. I'm just going to say some people. The family thought that the patient was dead, and that the EMT and the paramedic were breaking the DNR by providing those rescue breaths, and they wound up winning the case because as long as your patient has a pulse, it's not a resuscitation effort. That was the difference. Because you can stop breathing for a number of reasons other than full respiratory arrest. Respiratory arrest is a symptom. It's not usually a cause of anything. Other names for advanced directives, we have living wills, healthcare directives. A living will is kind of like, it's not a will as in I'm going to give you my PlayStation if I die. It's a will like, for example, for me, like I said, I have this phobia of Foley catheters. I refuse to get them. So if I wasn't so lazy, I would go get a living will that said, provide all treatments to me except this one thing. And then so if I'm knocked out, they can do everything, and I can rest assured that unless they don't listen to my my legal documents, I won't get a catheter. That's an example of that. There's going to be people that say, I do want resuscitative efforts. I just don't want chest compressions, which kind of, it really puts that in close to a DNR. But they're like, you can do everything else, but don't do this. DNR orders must meet the following requirements, and it must meet all of these. So if you guys get one and one of these is not met, it's not a valid DNR. Ignore it. So first of all, it should have a statement of the patient's medical problems. It should have a signature of the patient or their legal guardian if they're not one that could ever make that decision. Signature of the physician, and it must not be expired. So there's been a few times where I've had people come up and, we're getting ready to do CPR on somebody and they run in the room and like, we have a DNR. And I look at it and like, this expired 2 years ago. We can't go off of this. The patient, when they get the DNR, they are explicitly explained to and made sure they understand that those DNRs are only good for so long, that they have to keep renewing them. So sometimes you may see that and it has to be present. You have to actually be able to see it. If they run in the room and say this patient has a DNR, and you're like, cool, where is it? And they're like, well, we don't have it. I'm like, well, if it doesn't exist if I can't lay eyes on it. So then you would at that point go ahead and give care. This is an example of an advanced care directive. All right, so this is where you can see all the information of what they need on there. Physician orders for life-sustaining treatment and medical orders for life-sustaining treatment. These explicitly describe acceptable interventions for the patient and must be signed by an authorized medical provider. So again, if it's missing signatures, it doesn't count. If you are in doubt though, let's say they've got everything, but it looks like there's just a smudge where the signature might have been at one point, you can contact MidControl and let it be their decision. It's real easy to pass the buck just to make sure. So don't be afraid to do that. Some patients may have named surrogates to make decisions for them when they can no longer make their own. Again, that's where, like I said, before my last deployment, I gave my wife my power of attorney. If I came back in a vegetated state, I was giving her the ability to make decisions for me, all the way up to canceling life support if she decided she needed to, or if it was looking like I wasn't going to come back in any real recoverable state or anything like that. But thankfully, none of that ever happened to me. These are also known as healthcare proxies. So the person has to be in there. Again, all this has to be set up when they are completely alert and oriented and in their right mind and everything. They will sign over the authority to take care of them to somebody else. So you see this a lot with either people in high risk career fields like mine, and some of y'all will probably do this as well. You see it a lot with elderly patients that may be going, like they're starting to get Alzheimer's, for example, and they realize that eventually they're going to get to where they may not always be lucid to make their decisions. They'll go ahead and build a durable power of attorney for that. Because of the growing number of hospice home health programs, you may be faced with this situation often. It just kind of depends on where you're at. I've worked for places where that was the bulk of our patients because everybody was retired and there was hospice homes everywhere, nursing homes and stuff like that. And then I've worked in places where it was just trauma all day long. That was it. No medical hardly. When presented with an advance directive, you should never become annoyed with family members. The patients and their families should be treated with the utmost respect and empathy, but you also have to be realistic with it. I hate to say it, some people have ulterior motives. Somebody runs in screaming, "Don't resuscitate him, he's got a DNR," but has no proof of it. You don't know. It could be somebody that's thinking about the big life insurance check that's going to come in if they pass away. I'm not saying that that's why they do it, but it would definitely be a motivation if they knew there was some massive check coming. And that does happen. It happens a lot. So if you do see it, if they do say anything about an advance directive, make sure you lay eyes on it and that it is valid. All right. It's 7:00. It's been an hour. Take a 10-minute break. Be back at 7:10 and we will resume. To anybody that's still at the computer, I'm sitting here fighting with the orientation on these slides. Is it still looking right to anybody that's there, or does it look like it's overblown and words are off the screen? Awesome.
I can
I
see the
appreciate
slides
it.
fine.
Okay, just making sure. And my little preview pane is it's not always accurate, and I'm glad to know that now is one of those times. Winston Navarra at Moss Point. Oh, no, yeah. You don't have to update it for me. I was just making sure I was looking at the right account. All right, I just sent you a friend request. All right, we're back. Just trying to work on a couple things. People are still working on getting some guys into the Facebook group. Alicia Williams. So, Kendra, I'm going to have you probably try to search me up because there's a lot of you in the search results on Facebook. I'm not sure which one's which, but we can work on that afterward. We'll get back to the lecture for now, and then we'll go from there. Just remind me. I got so many things going on. Little things will slip through the cracks, and I apologize for that. All right, so let's talk about physical signs of death. Right, you show up to somebody's house, and it's the interesting thing. I don't know if y'all saw this in the news recently. Somebody had pretty much called somebody dead at the scene. They made it as far as the morgue before waking up. Did anybody hear about that in the news? That's some wild stuff. You know, you're about to be put into the oven, and suddenly you wake up. That'd be the day I would I'd quit. I'd be like, that's it. This is not the career for me. I think I just saw a zombie.
What was it again, Mr. Robert?
The what?
What were you talking about that was on the news?
So there was a person that was found and declared to be dead in their house or something. I forget. I didn't get to read the whole story, but they were pronounced dead at the scene, and they made it as far as the morgue before waking up. I can't imagine what it was like for the the guy working there to have somebody that he thought was dead on a table sit up or something like that. It would be at
Yeah,
that
I did
moment
see
that I
something.
noticed.
Yeah, I did
Oh,
see
that
something
too.
about that. I was thinking, man, what if that was you back there? What you probably be freaking out.
Mhm. You ever hear a 37-year-old man scream like a little girl? That would be me.
I don't know if I'd be able to do that.
Yeah, I don't know. Like I said, I got to go find it and look at it again. I'm not sure if it was a frostbite dude or not. I just remembered seeing that particular part and going, well, yeah, that would be the day that I picked a new career field and probably never went to sleep again. So anyway,
Yeah, I saw
determination of
that
the cause
article.
of death. Oh, you did? Yeah.
Yeah, I saw that article. It was a black lady at a funeral home in Atlanta.
Yeah. It was down there somewhere. All right, so determination of the cause of death is the medical responsibility of a physician. So we don't really do it in the field. We're not, at least not ourselves. Now we will be the ones to try to get the information for the physician to make that decision, but we're not going to be the ones to say, yeah, he's DED dead. In the absence of physician's orders, the general rule is if the body is still warm and intact, initiate emergency medical care. DNR notwithstanding. Cold temperature emergencies are an exception to this because your patient may just be in a coma basically because they're extreme hypothermia. Some presumptive signs of death. So you have unresponsive to painful stimuli, lack of a carotid pulse, absence of chest rise and fall. Pretty much all the same stuff that would make you want to do CPR on somebody so far. No deep tendon or corneal reflexes. Be careful with that. All right, you're going to lose reflexes if you go completely unresponsive. You may have a person they're perfect. They're very much alive, but they don't have any reflexes. Absence of pupillary reactivity, no systolic blood pressure, profound cyanosis, and lowered or decreased body temperature. So these are all things that are signs. Well, no, let me go. Okay. These are all presumptive signs of death. Try to get as many of these as you can before you start thinking about calling somebody dead, because like I said, a lot of the stuff is just cardiac arrest and you can really get them back. Definitive signs of death, these are the ones that they are definitely not coming back if you see this. So obvious mortal damage, like a decapitation. If the body's in one place and the head is somewhere else, there is no getting them back. Dependent lividity, which refers to the blood settling to the lowest point of the body, because gravity, the blood's not moving anymore, the heart's not beating. Gravity will eventually start to pull the blood down, so you're going to get that dark red look, and it's going to look like they've got all the blood in their body is sank to the bottom, and you'll see it discolor the skin. Rigor mortis, which is a stiffening of the body muscles caused by chemical changes within muscle tissue. This usually occurs pretty soon after death, so 2 to 12 hours. And I want to point out something. Rigors does not last forever. It really doesn't last that long, actually. So if somebody's been dead for more than 24 hours, the rigors is already going to wear off. They're going to be back limp again. And then putrefaction. So this is decomposition. One of the first medical calls I ever ran was for a guy that was killed in a car wreck. His car was not seen for about 6 days. It was off an embankment. And he was already to this point when we finally found his car and started trying to pull him out of it. We had bugs crawling in and out of him and stuff like that. So why I'm still a firefighter, I have no idea. This process this takes a little while to get started. Decomposition doesn't happen immediately. If you start to see signs of that, they've been dead for a couple of days at that point. Some medical examiner cases. Involvement of the medical examiner depends on the nature and scene of the death. So if it looks to be violent, if it looks like it might have been a crime of some sort, you're definitely going to want to get a medical examiner out there. A lot of times the police will try to get one as well, or they'll bring one. And it pretty much just kind of plays out a little bit, not overly dramatized, of course, but it kind of plays out a little bit like a mystery show on TV. The ME is out there looking at those signs that we just talked about, trying to determine a real quick cause of death. If they think there was foul play, how long ago did they die, and all that stuff. In most cases, the medical examiner or the coroner must be notified in the following cases. So a patient who is dead on arrival, death without previous medical care, or when the physician is unable to state the cause of death, suicide, violent death, poisoning, death from accident, suspicion of a criminal act, and then anything involving infants and children. You should make every attempt to limit your disturbance of a scene involving a death. You kind of treat it like a crime scene, even if it's not one, right? The more you move stuff around, the worse it is and the harder it is for people to figure out what happened. So tiptoe around these things. Do what you need to do with as little disturbance to the patient and to the scene around you as possible. That way, the people that are doing the investigation can actually get a good look and idea of what's going on. If emergency medical care has been initiated, keep thorough notes of what was done and found, because in the event that it looks like it might have been a malpractice issue, it's probably going to go to court, and you don't want to have like a hole in your documentation or no documentation. That's a horrible situation to be in. Make sure that you document everything thoroughly. Organ donors. All right. I myself am an organ donor. I don't know about you guys. I know it's a definite choice of yours, whether you are or not. But those that have, we have basically expressed a wish to donate our organs. Consent is evidenced by information on a donor card or the driver's license. I think most states put it on their driver's license now. I know every state I've ever lived in has. Your priority is to save the patient's life, but remember that the organs need oxygen. So even in the event that somebody, say you're doing CPR, you show up to somebody that's in cardiac arrest, you're not your priority is to save their life, but you're not just doing it for that. If they look like a lost cause, you're probably going to still wind up doing some CPR or providing oxygen or something just for their organs so that you can hopefully salvage some of that, because that was their goal in life when they made that decision. So you're still doing them and their family a favor, even if you're not getting them back. But you might have to explain that to the family. If the family's like, they're like, why are you working on him? That kind of thing. Like, well, because he's an organ donor. Medical identification insignia. If this is what you see, and well, so not if this is what you see, but keep an eye out for these bracelets, necklace, keychains, or cards that indicate a DNR order, allergies, diabetes, epilepsy, any other serious condition that you might need to know about if they are not awake. Now, I will say this. These do not take the place of a DNR order. Just let it be a cue that you need to be looking for one. So if you get ready to start beating on somebody's chest, and you see that doesn't mean don't do it. That just means that there might be one, and then go from there. So okay, yeah, I'm glad you put this. Mine's tattooed on my wrist. Are you talking about a DNR? Type 1 diabetic. Okay. All right. Yeah, I was about to say, um, because yours is something that's not going to change. That's a good thing, right? So that they know you're type 1 diabetic, because that's massive. We really can't do a lot with type 1 diabetes in the field. Even as paramedics, they're kind of limited. But DNRs, you're going to see people with DNR tattooed on their chest, because that way it's seen when the responder goes to do compressions. The problem with that is that tattoos, for the most part, are permanent, but a DNR is not. So if I wanted a DNR right now, and then I had the harebrained idea to go and get that tattooed on my chest 20 years from now, I may be like, you know what, I want to have every chance. I don't want to keep my DNR. Well, I got this DNR tattoo on my chest that, hopefully the responder doesn't see it and make the mistake of taking that as being the law and saying, oh, he's got a DNR, it's tattooed right here, so we're not going to do that. And then I'm going to be going into a box rather than going into the hospital. So that's just something to keep in mind. Those things like that, even stuff that they're wearing on their bracelet or on a card or something like that, let that be just a warning, not a stop, right? That should tell you that there might be a DNR in the place somewhere. And you can have a family member, if they're there, you can have them try to verify it or furnish it or something like that. The only other thing I want to point out with this, just because these slides don't very often get updated, anybody with a smartphone, I know that iPhone does it. I'm pretty sure Android does too, because they're practically the same phone. A lot of people will put their health information on their phone, and you can access that from the lock screen. So if you're looking with somebody, you think that they might have some kind of, you want to know if they've got anything, grab their phone if it's nearby. And if they have put anything in there, their lock screen is going to have a little icon on it that says like Med ID or something like that. And then you'll be able to see whatever it was that they wrote. And you don't have to deal with trying to unlock the phone to get to it. So it's a real quick, easy to look for thing. You can kind of add that to your list of what you're looking for when you're looking at things for your patient. All right, so there's your example. Let's talk about scope of practice. Now, we hit on this a little bit when we talked about what the levels of EMS were in Chapter 1. So now we're going to talk about it from a little bit more of a legal standpoint. Your scope of practice is basically your limit of what you can do for your particular scope. We have some EMRs in here. You guys have already, like I said, y'all know this chapter. You already know what your scope of practice is. They had, before this class, they had a set standard of what they could do, and then anything that went beyond that, they basically had to stop and say, I need an EMT for this, or hire care or something, and you guys at the same time are going to do the same thing. You're going to do everything you can up to a point, and then at that point, your scope of practice ends, and you have to make the decision that you need somebody higher up, be it an advanced EMT or a paramedic, to come in and provide the rest of the care. These are usually defined by state law. So all the national registry states like Arkansas, Alabama, all you guys that are in the class, your states pretty much have the same scope of practice, but there might still be some minor differences. So I'm going to teach you guys as generically as possible and cover all of our bases. But when you go to work as an EMT in your state, take a look at the protocols, because, for example, for the longest time, Mississippi EMTs couldn't give aspirin and they couldn't do a glucose stick. It was considered invasive because you had to break the skin. You go 10 miles west out of Poplarville into Bogalusa, now you're in Louisiana's territory. Those guys could do that stuff. They also could do LMAs and things that, Mississippi was way behind on catching up to. That was a few years back. A lot of that stuff you can do now in Mississippi, but back then it was a little difficult. Where I lived right on the Pearl River, so I'd go to work for the Mississippi side of the river on the ambulance, and my buddy would go to work in Louisiana on the other side, and there was a lot of things that he could do that I wasn't able to, and I caught crap for that all the time. But I mean, that's the breaks. That's how it goes. Anyway, medical director further defines the scope by developing protocols and standing orders. So your scope of practice is basically that's your baseline of what you can do, and then your med director can change things from there. Carrying out procedures outside of the scope of practice may be considered negligence or even a criminal offense. It just depends. So you have to be careful about that. You have to know where your limits are. Even though you might be trained to do something beyond that, you still have to operate within the scope of practice of your agency. So me as a military medic, they put us through 6 months of intense medical training. The first 6 weeks was EMT. Everything after that was more advanced EMT and like LPN level stuff. We learned all kinds of things that we could do in the military. It's fantastic. But if I left the base and went to work for a civilian agency, 80% of the skills I knew how to do, I was not allowed to do. So you have to be cognizant of that. Here at Cullen FD, as an EMR, we have the right to do a glucose stick, but our protocol tells us we aren't allowed to. I don't quite. If your protocol says not to do it, and that's the protocol you're following, how is it that you're able to do that? And while you're typing that, Mississippi is behind on a lot of. Yeah, they are. They're working on it. I will say that the guy that's in place at the EMS office up there right now, he's done a lot to try to catch Mississippi up, which is pretty good. But there's a lot of red tape that goes into that, because you're talking about basically bylaws and policies that have to be voted on. So it's never going to be a fast change. Yeah, I'm curious, Clay, how that. I don't know. I guess maybe it's a southern thing. But you guys are actually y'all are doing pretty good with like the compact and everything. Y'all have embraced National Registry for the most part, which is a good thing.
Hey, Robert, it's Clay.
Hey, go ahead.
Hey, according to Acadian for the state of Louisiana, they said an EMR is eligible to do a glucose stick, but our protocol says that Cullen FD we're not allowed to.
All right, yeah, you have to follow your most local protocol. So for you at Colon FD, if you're on shift with them, you can't do it. The sad thing is, though, is you can get off duty at the fire department and jump on the ambulance as a second job, and in the exact same house, you can do a glucose stick, because it depends on who you're operating under. When you leave the fire department and go to Acadian, you're operating under a different med director. So they have that. They have the ability to say that. All right. Authorization to provide care is given by the medical director via telephone or radio. That's your online protocols, or standing orders of protocols. Like, you're going to be able to download a big PDF that says, if this is what you see, these are the steps that you need to do before anything else. You reach the end of these steps, if it hasn't fixed the situation or at least gotten you to where we expected it to be, then you call MidControl. You tell them that you've this is what you've done, this is the vitals you've gotten, and they may give you some other steps. Nitro for a cardiac patient is an online scope, or is an online policy, so you're going to have to actually call MidControl every time. Let me type something real quick. Okay, let's see. So we already said that what was on the slide. Don't confuse scope of practice with standards of care, which are what a reasonable EMT in a situation should do. So your standards of care is basically the nation says this is an EMT skill, all right. But your scope of practice is what you're stated, or more narrowly, is saying that yeah, that's cool, you're trained for that, but we're only going to let you do this. All right. So your standards of care. This is the manner in which you must act or behave at all times. We do have standards that we have to take care of. You have to be like a patient advocate, for example. You always work with your patient's best interests in mind. You must be concerned about the safety and welfare of others. That's just part of your job. We really don't make a lot of money in this field. I can't imagine why anybody would get in this field for anything other than to try to help people. I mean, that's what we do. The law requires you to act or behave toward other individuals in a definite, definable way, regardless of the activity involved. And a lot of it is also regardless of how you feel about it. You may show up to, like I said, 100 junkies or overdoses of various types, but you still have to treat them with all the same dignity and respect that you would treat if it was just your grandfather forgetting that he took his meds and then doubled up on it. Generally speaking, you must be concerned about the safety and welfare of others when your behavior or activities can potentially cause other injuries or harm. So your standards of care are defined by local customs, especially when you're starting to deal with, say, like Indian reservations or something like that, because a lot of times they have their own ambulance, they have their own law enforcement and all that stuff. State law and ordinances can determine how your standards operate. Again, one ambulance company I worked for, we were able to proactively go to people's houses that were our frequent flyers for non-emergency reasons. We would go to them and just do a quick checkup, see how they're doing, that kind of thing, because it stopped them from calling us. That was something that my agency allowed. I don't think every agency will let you do that. So, if that's something that you want to bring to yours, then take it to the powers that be and let them make that decision, because it could also be seen as harassment if you're not careful. So you just want to, like I said, run that up your chain, see if it's something they want to do. Professional standards, so like AHA CPR guidelines, they dictate that if they're in cardiac arrest, this is what you're going to do. You're going to do 30 compressions, 2 breaths. If you're ACLS trained at a higher level, you have all your algorithms. For a STEMI, you're going to do this. And PEA, you're going to do that, so on and so on. All right, and then standards imposed by the states. Every state has their own way of doing your credentialing and your licensing. It's just, but they're all usually pretty minor. So, yay for y'all, kind of stinks for us because we have to reinvent the wheel sometimes with the states that we teach in. But that's just how it goes. All right, your duty to act. People mess this up, surprisingly. I mean, it's not that hard, but it can be confused. So this is your individual responsibility to provide patient care. Let me ask you this, and y'all type this because there's 29 of you in class tonight. If you are working on the ambulance and you go to lunch at, we'll say, Firehouse Subs, for any of you guys that have those in your area, and you walk out with your food and you see somebody laying unconscious on the ground, do you have a duty to act? Yes, good. Okay. Now, let me ask you this. You're on your day off and you're on your way to a football game or something like that, and you come across an accident on the side of the road. Do you have a duty to act? No, not for that. If you're off duty. Yeah, I say, all right, so Good Samaritan, you guys are right. Now, here's the thing. You don't have a duty to act. You're not required to act. And I've heard this in the past where people say, well, what if you have like the firefighter license plate or a Star of Life sticker on your window or something? That doesn't suddenly make your vehicle an ambulance. So no, you still don't have a duty to act. However, if you choose to, and most of us would, again, we take this career because we want to do the job, not because we're trying to get rich. Should you choose to act, if you're on your own time, then you're acting under the Good Samaritan law, which means that you can do anything you're trained to do. It gets a little, I tell you what, I'll use my example again. So like I said, I'm a military medic. For a long time, that was my highest level training. So I'll get to the volunteer thing, and that's actually a good point. But if I'm off duty and I'm trained to a military medic level, if I'm not working actively for my fire department as a civilian or an ambulance as a civilian, I can do everything in my scope. I can operate as a military medic and be protected by the Good Samaritan law because I'm still only doing what I'm trained to do, even though I might be operating beyond an EMT basic. When I put my ambulance uniform on and I'm on the truck, I am confined to EMT basic. But I also have a duty to act at that point because I'm in an official role. Now, you guys that are volunteers, you would think that you have a duty, but you actually don't. As a volunteer, you at no point have a duty to act. You can just say, I choose not to invoke my role as a volunteer firefighter and do this. Now, obviously, if you are responding, the minute you come across the radio and say that you're en route, you have provided the grounds for your duty. At that point, you got to go until the IC or whoever tells you no, or tells you to go back to the station or to your house, because you've set yourself officially into that call when you did it. Let's see, no, but if you have a professional fireman or EMS license plate and someone sees it and you don't, they could push. So yeah, they could push the issue. They can complain. They can file suit. They can all that stuff. But your own time is your own time, and they can't force you to do it. You're not a slave, and that's what it basically comes down to. So yeah, they can make a fuss, and it may look pretty bad, but ultimately you're going to win that argument. But if you operate off duty, you're protected by the Good Samaritan law. So if you're a 4N in the military, med tech, or a combat medic in the Army or something like that, it's actually pretty cool when you get to do stuff off the clock because you get to operate to full capacity if you've got the equipment for it. Whereas if you're on duty, you have to play more by your rules. But once your ambulance responds to a call or treatment has begun, you have a legal duty to act. And what that's saying is, like, let's say you're already en route to another call and you see one closer. Do you have a duty to act on the one that's closer? Not necessarily. So if you've already been assigned to a call and you're en route to that one call, you don't have a duty to act to stop at the one that you just passed. Let's say there's an accident that happens because you're going down the road with your lights and sirens and people are freaking out, because that always happens. What you would normally do is you're going to radio to dispatch and say, hey, dispatch, this is medic, blah, blah, blah. We're on our way to such and such address. We just witnessed an accident at the intersection of wherever you're at. We're going to need you to send another ambulance. Yeah, so you call for backup. You don't have to stop, because if you stop, you're in threat of being charged with abandonment of the patient you were already going to. So let dispatch make that decision. They may be the ones to say, you take that call and we'll send another ambulance to your original address, because they also know where all the other ambulances are. Let's see. You can radio out. Okay, yeah. Why does dispatch send fire and ambulance to a diabetic? It just depends on where you're at. Hold on, let me mute everybody. All right, so some fire departments they call it a call matrix. Dispatch has a list that says, if I have this call, I'm going to tone out these people. And it's just basically whatever agreements are set with the county and with the the city that has the fire department and stuff like that. A lot of times, not all fire departments will respond. A good example of that would be like lifting assist. Most fire departments will go to a lifting assist, but I know at least one department that doesn't unless they're specifically asked. Some fire departments don't run medical at all. So fires in one spot, buses are stretched out everywhere. I'm not sure what you meant by the first one, Rob, but yeah, if you call 911, you get both. All right, moving on. I'm going to talk about negligence. So this is where you are providing your care, but you're not doing it within the scope that you're supposed to do or to the standard of care that you're expected to provide. So let's say you're doing CPR. All right. Negligence would be you didn't, if you're a paramedic, it's an example. Let's say you're a paramedic and you're doing CPR. Negligence would be that you didn't bother with any of your ALS drugs. You just did basic life support. You had every opportunity to do what you needed to do at the advanced level, but you chose not to. So it's not that you abandoned your patient or that you just refused to do their treatment. You knew you had to do a certain standard and you didn't do it. And that can happen for a couple of things. People have gotten hemmed up because they responded to somebody that was obviously strung out on a drug, and because of their personal views on that kind of lifestyle, they chose not to provide care. I've actually seen somebody stop doing CPR because somebody was wearing a Bernie Sanders shirt. And I mean, I've seen memes and videos of people doing that, but I've seen it actually start to happen. The guy was like, no. And I can't believe that I can actually say that that really happened. And come on. But it happens. It happens all the time. But you very much will get caught up in court and lose that case. It's a very expensive point of view to have. All four of the following elements must be present for negligence to apply. I'm going to foot stomp on this one because I know I've seen this in some testing, not necessarily on the registry, but just in general. If you are worried about whether or not you're going to win or lose a case about negligence, they have to be able to prove in court that all four of these have it. First of all, you had to have a duty to act. That's why we talked about that a second ago. If you're off duty, you can't be hemmed up for negligence because you don't have the duty to act. But if you do have it and they can prove that you breached that duty, you caused damages. I'm sorry, there were damages, and those damages were caused by your breach. So negligence is pretty hard to prove, unfortunately. If you really do lose a case of negligence, it had to be pretty blatant. So it's a saving grace for you in a way, but at the same time, hopefully you never ride that line anyway. I like to think that people keep their integrity up, and that's not an issue. Abandonment. This is unilateral termination of care by the EMT without the patient's consent, and making provisions for continuing care. So let's say you're working on a call and you just don't want to keep doing it. So you stop, all right, and you stop without good reason. That is abandonment. If the patient tells you to stop, you're okay because that's the patient's right. If you're doing CPR for 45 minutes and you are just utterly exhausted to the point where you can't even stay upright anymore, that's a time to call, and that's okay. That you're not going to get hemmed up. Physical exhaustion is a legal reason to stop. But if it's just because you just don't want to do it anymore, that doesn't count. You'll get in trouble for that one. Abandonment may take place at the scene or even in the emergency department. So it can happen after you've dropped them off. It could be when you drop them off. One of the things you have to make sure you do if you're a transport EMT is you have to make sure that you properly hand your patient off. So you can't just wheel them into the ER, see everybody's busy, and then like walk out. You're still technically you've ended their continuity of care when you do that. So there are times where you may walk into an ER with an ambulance with a patient, and you have to kind of just hang around and wait for 20 minutes while you wait for a nurse to come up and take a pass down from you, and then take your patient. So make sure you don't do that too early. If you bounce out of there because dispatch is yelling at you to get onto another call, if you're stuck waiting on dropping off the patient, that's dispatch is going to have to find another ambulance at that point. Always obtain a signature on your patient care record, whether it be for a refusal or for transfer of care. Usually your paramedics are doing this because they're the ones holding the laptop for the report, but sometimes, especially if you're on a basic truck, you may be doing this as well. But you have to get a signature saying that that care was transferred. Assault, battery, and kidnapping. Assault is unlawfully placing a person in fear of immediate bodily harm. All right, that includes threatening to restrain a patient who does not want to be transported. If you don't need to restrain them, if there's no medical necessity for that, and you threaten it, that is assault. Battery is unlawful touching of a person, so this includes providing emergency care without consent. Again, if I don't want the catheter and you give me a catheter, that's battery. Kidnapping, that is where they say they don't want to go and you just throw them in the truck anyway. You can definitely kidnap adults. That's seizing, confining, abducting, or carrying away by force. This could include a situation where a patient is transported against their will. And a false imprisonment charge is more likely because EMTs are almost always acting in good faith to provide care. So if this happens, like let's say your med director says, get him here, I don't care what you have to do. And you like, all right, you basically get him, throw in the truck. He's saying he doesn't want to go, but you're pushing and prodding and saying, come on, we need to go. You're more likely to be hit with a false imprisonment charge rather than kidnapping, just because the court's going to kind of smile on why you did it, even though you screwed up. False imprisonment is the unauthorized confinement of a person, so you're not going to get hit with kidnapping. Or at least you have the potential to not get hit with kidnapping. Serious legal problems may arise in situations in which a patient has not given consent for treatment or transport. This is the kind of stuff that really gets you thrown into court, and it's never pretty. And sometimes the stuff happens way after the fact. So if you really didn't mess up and they are trying to say that you did, this is why it's so important to have your documentation squared away, because it may be 10 years later or 9 years later and you don't even remember the person or the call or anything, and they're asking you all these detailed questions. You want to make sure that your report is thorough enough to answer whatever they throw out there, so that all you have to do on the stand is just sit there and be like, what's my report say? What's my report say? It's in my report. If it's not in my report, it didn't happen. And there's no room for you to have to speculate and be picked apart by any other lawyers. Defamation. Defamation is the communication of false information that damages a person's reputation. And this can be either written or spoken. Libel is where they wrote it down. So if you put something in your report that is false information and can damage reputation, that's libel. If you talk about it, that's slander. Libel is more common for us because of our report writing. You have to be very careful when you write a report that you don't put something opinionated in it. For example, if you show up to a car accident and you smell alcohol on one of the drivers, can you put into your report that he was driving drunk? No. Why not? Let's say you smell alcohol, you see an empty bottle in the car. Okay, so confidentiality, but putting it into your report, your patient care report, you can put whatever, there's no confidentiality law stopping you from putting something in there. But that's it right there. Carmen hit it, because that's an assumption, right? What if the bottles were in there from a previous time? What if he spilled the alcohol on himself? He wasn't drinking it, but he spilled it on us. So now you smell it. So without that definitive that knowledge, you've speculated in your report. And here's the issue comes about when that gets brought into court and picked apart, and they see that you speculated something, it completely undermines everything else. So you want to make sure that whatever you put in your report is completely factual and only that. You can put in there that the patient had the smell of alcohol on them. That's fine, but you can't actually say that the patient was inebriated or something like that, because you don't know for sure. And even if they do a field sobriety test, correct me if I'm wrong, guys that are in law enforcement, but those things aren't always accurate. Doesn't some mouthwash set up or mess up breathalyzers? I have heard that like, okay, yes, yeah, I was gonna say I've heard that something like Listerine um, will set off a breathalyzer. And gum, I didn't know gum would do it. That's interesting. I gotta stop chewing gum when I'm speeding. All right, moving on. Defamation can happen with a false statement on the run report, like we were talking about, and inappropriate comments made during a conversation. The run report should be accurate, relevant, and factual. Make sure that you are completely objective. If you want to put in there something that marks down that you think they might have had alcohol in their system, just be very, very, very careful how you word it. Right. And communicate information about your patients only to authorized person. So again, you can put whatever you need to in the report and not worry about HIPAA. It's HIPAA really concerns itself with who gets to read that report. All right, we're getting pretty close. 10 more minutes, we'll take a break if we're not already right at the end. Good Samaritan laws and immunity. So again, these typically apply to either, I'm not going to say untrained people, but it definitely applies to you when you're off duty. So if there's no duty to act, you're not really held to your department's standard and scope because you're not on duty. The Good Samaritan law is what kind of allows you to operate and be safe from being a lawsuit. Now, this is not something that will guarantee you immunity. There's been times where the Good Samaritan law has failed to protect somebody, but usually it's because of something else they did that made it not just, it just wasn't a good enough excuse or a good enough defense. Good Samaritan laws are based on the common law principle that when you reasonably help another person, you should not be held liable for errors or omissions that are made in giving care. The problem with this is that it's only good for up to what you're trained for. And some errors are not just accidents. I mean, yes, sometimes there are, but a lot of times it's because you were negligent or something like that. And the Good Samaritan law, if they can prove negligence, the Good Samaritan law won't protect you, that kind of thing. But Good Samaritan conditions to be met have to be good faith, without expectation of compensation, within scope of training, and you did not act in a gross and negligent manner. That second one, without expectation of compensation, is one of the reasons why Good Samaritan laws don't apply to you when you're on the ambulance, because you are definitely working for usually a for-profit company. At least down in most of the southern areas, I know all of those. I don't know of any volunteer ambulance companies down there. Up here, they're pretty common. Gross negligence, conduct that constitutes a willful or reckless disregard for a duty or standard of care. And another group of laws grant immunity from liability to official providers such as EMTs in some circumstances. So one of these that I want to talk about is the fireman's rule. Well, let me ask you this. If you walk into somebody's house to try to take care of them, all right, and in the process of taking care of them, you trip over a table and you dislocate a hip, or you insert injury here, whatever it is, can you sue the property owner, the patient, for your damages? I want to say this is one of y'all's discussion questions. No, you typically can't, right? Because you are accepting a level of risk that says you understand what kind of situation you're going into, right? So if a firefighter runs into a burning building and gets burned, well, he chose to do it. That was his job description. So you can't really say that. That's what that rule is designed for. It's actually meant to protect the patient. However, over the years, they have found where that's actually kind of been a problem, because let's say that you go into a burning building that happens to be a meth lab and the meth lab blows up. Can you sue the homeowner for that? Okay, yeah, so this is a gray area one. It depends on your state, because this is technically a state law. Almost every state has a fireman's rule, but they look at it differently. Some states will say yes, if the homeowner is engaged in an illegal practice or something that's grossly negligent that leads to the damage, leads to an injury of a firefighter, the firefighter, the homeowner or the person in charge of that area could be held liable because that is out of the reasonable expectation of what a firefighter is going into. Our gear is not really designed to protect us from a meth lab that blows up, as an example. So I've heard of EMS saying they have to bring the ill person to the road because it was too dangerous to get to the home to get them. Yeah, that happens a lot. And that we're gonna beat that to death when we start doing your assessments, because the very first thing you do is BSI scene safety. So put your gloves on and make sure your scene is safe. So yeah, that's common. You might find that you can access your patient, but it's not safe to stay where you're at. So you can always move your patient. Records and reports. You should compile a complete and accurate record of all incidents involving sick or injured patients. Try to be as thorough as you can. Like I said, this stuff winds up in court cases sometimes, so don't be afraid to say the same thing. If it's something that you feel is a critical thing that could be brought up later, don't be afraid to just constantly. You can word it 3 or 4 different ways as long as it says the same thing. Don't confuse yourself with how you're doing it, but make sure that it is very well documented. Such a record is an important safeguard against legal complications. The court's perception of records and reports. If an action or procedure was not recorded on the report, it was not performed. So just like you hear it in fire departments and hospitals, if it didn't get documented, it didn't happen. Incomplete or untidy reports are evidence of incomplete or inexpert emergency medical care. They will judge you by how your report is written. They will judge you by your grammar, by your spelling. They'll judge you by how many acronyms you use, especially if you use them properly or not. My advice is try not to use acronyms unless it's something that is just everybody knows it, like CPR. Everybody knows what CPR is, even if they don't know how to do it. They know what that's referring to. But COPD, not everybody knows what that stands for. So at least at first, like when I'm writing a report, and there's a whole chapter to reporting that we're actually gonna skip that chapter because everybody does their own reports. But for me, if I can give you guys any advice, especially on the possibility of winding up in court, the lawyers that are going to start critiquing your reports in these cases, they're not EMTs. They're not medical professionals. They're lawyers. So they're not going to know what COPD stands for. They're not going to know what RSI stands for if you're a medic and you write that down. What I do is I'll spell it out once, and then in parentheses, I'll put what that would be as an acronym. So I say, chronic obstructive pulmonary disease, and then in parentheses, I'd put COPD. And at that point, I can use COPD pretty much anywhere else in there if I'm going to refer to it. But this way, it's in there spelled out. So if they do see an acronym they don't know, by the time they see the acronym, they've already read what it stands for. Just something for you guys to take. Yeah, SOB, shortness of breath in the medical field, but to anybody not medical, it stands for something very different. They advise us to use Grammarly when documenting your case, so your spelling and wording is correct. That's good. And a lot of your reporting systems actually have spell checker and everything built into it now too. If you don't have that, you can type it in Word, run your spell checker there, and then copy and paste it over. Just be careful, because remember, now you're doing patient care stuff outside of a report. So if you're going to go that route, make sure you're not saving it or anything like that. Clear it out, close it, so on and so on. Okay, moving on. The National EMS Information System, or NEMSIS, provides the ability to collect, store, and share standardized EMS data throughout the United States. And we mostly use this to improve the speed and accuracy of data collection. So it really helps, and it also helps in documents that lead to better research stuff, and that's what changes our CPR regulations and what all we do with that. That's why we haven't used IPACAT in like more years than I've been in EMS, because I've never used it, but we still hear it and talk about it. All right, it's pretty much 8 o'clock for you guys. Take another 10-minute break. Be back at 9:10. No, I'm sorry. I'm looking at the wrong time zone. 8:10. Be back at 8:10, and we will resume. All right, everybody. Been 10 minutes. I actually, we're only about 10 minutes away from being finished, so we're pretty close to being done. We're just going to talk about some mandatory reporting requirements and a couple other things, and then we're going to call it a night. So this is one of those nights that you're actually going to get done fairly early, a whole lot better than the other night. Anyway, most states have a reporting obligation for certain individuals, ranging from physicians to any person. The following special mandatory reporting requirements may vary from state to state. So abuse being at the very top. Now there's a couple different things. Obviously you have child abuse, elder abuse, at-risk adults. If you see any of that, you're going to have to report it. Injury during commission of a felony. So bank robbery, or I'm sorry, and we're talking about the actual felon here. So somebody got hurt while trying to stab somebody else, or trying to shoot somebody. They shot themselves in the foot. Drug-related injuries, childbirth, attempted suicides, dog bites, certain communicable diseases. So if somebody has AIDS, you have to report it. Now, which diseases you have to report? I think herpes. I think herpes is a mandatory report. AIDS is a mandatory report. Check with your systems, and you'll be able to know which ones you have to watch out for. Some you don't really have to say anything, but those have to be reported. Assaults, domestic violence, sexual assault or rape, exposures to infectious diseases. Again, and that's for your own safety as well. Transport of patients and restraints, scene of a crime, and the deceased. You would think gunshots would be on there, but if you're going to take them to the hospital, that's going to be pretty well known anyway. Some ethical responsibilities. In addition to your legal duties, EMTs have certain ethical responsibilities as healthcare providers. Like we talked about the other day, and my Air Force nerdiness came out. Integrity was first. I like that. That's one of our core values. It should always be that way. As long as you are doing as long as you're doing by yourself what you would be okay doing with somebody watching you, typically you're going to be okay. Don't be two-faced. Don't be a klepto. Don't be these things that are going to get you in trouble in the long run. We know what's right and wrong for the most part, but golden rule usually applies. These responsibilities are to themselves, their coworkers, the public, and the patient. So ethics is the philosophy of right and wrong, moral duties, and ideal professional behavior. Bioethics specifically addresses ethical issues that arise in the practice of healthcare. So that's more your speed in your career, but it all basically falls down to morality and your ethics. EMTs will encounter ethical dilemmas. Such dilemmas will require you to evaluate and apply ethical standards. So you're going to be basically your own, which is what your mom and dad teach you to be right and wrong. What do you, as your own person, consider to be right and wrong? Some people don't see a problem with drug use. Some people do. It just depends on what your ethics tell you. Now, somebody smoking weed or something like that, as an example. Say somebody smokes weed. Is that ethically wrong in itself? Or we can even replace it with drinking alcohol. If somebody has a drink, is it ethically? Are they wrong for doing that? Maybe not. Especially if they're legal age. So if you're legal age, you're not getting behind the wheel, and even then, drinking the alcohol wasn't the problem. Getting behind the wheel was the problem. But now, if you drink on shift and you're trying to drive the ambulance down Highway 90 in Mississippi, and you're not sober, that's different. So, and then you also have the ethics of your profession. So I don't know if I can't say we all have heard it, but most people have heard of the Hippocratic Oath. That is basically an ethical document, more it's an ethical oath to basically do no harm to your patient. Be honest in your reporting and keep accurate records. So if you do wind up in court, and really and truly, I've been in court not because of anything that I did. I just got called in as a witness. So sometimes this may happen. Just because you get called into court doesn't mean that you're the reason that they're after you. It's not the case. In your career, you probably will be called into court, be it because of something that happened on your watch, or it could just be that they called you in as a subject matter expert or just a witness. But you can end up in court as a witness or a defendant, and the case can be civil or criminal. It just depends on what's going on. Whenever you're subpoenaed to testify in any court proceeding, though, you should immediately notify your service director. Notify legal counsel. You deserve a lawyer just like anybody else, whether you're a witness or what, because they're gonna, even though you're not the one on the stand being tried, the lawyers for the other team are probably still gonna try to hem you up and get, discredit you or whatever. So again, accurate reporting, be thorough. Try to make your report so bulletproof that you can just sit back in the sand, throw one arm over the back of the chair, look at the judge, and every question they ask you, you should say, "What does my report say?" I'm sorry, I can't recall. What does my report say? And hopefully your report is thorough enough that they don't even have to put you in the chair. The report says everything. So as a witness, though, remain neutral during your testimony and review the run report before your court appearance. That way, you're not trying to connect dots that you've long since forgot. Because sometimes by the time they call you up there, it could be 5, 10 years, maybe even longer. It just depends on what the issue is. If you're the defendant, you need an attorney. That's a requirement. Defenses may include statute of limitation, the time within, it's like, all right, this issue happened over 10 years ago and the statute of limitations is 10 years. So if they were going to try to get anything out of it, they should have hit you up before then, that kind of thing. Governmental immunity. So generally applies to municipalities or other governmental entities, not necessarily the person themselves. If your service is covered by immunity, it may mean that you cannot be sued at all, or that it would limit the amount of monetary judgment recovered. Sometimes you get this immunity if you go to work in another country, be it with the military or something like that. You may get immunity if you're over there helping with disaster relief, for example, something like that. Contributory negligence is a legal defense that may be raised when the defendant feels that the conduct of the plaintiff somehow contributes to injuries or damages sustained by the plaintiff. In other words, they did it themselves. And then discovery. Discovery is an opportunity for both sides to obtain more information to reach a better understanding of the case. And a lot of times this discovery happens before you ever get on the stand. 2 types of information gathering will happen. You have interrogatories where they're going to actually do requests, ask questions, stuff like that. And then you have your depositions, which are oral requests for questions. We actually, when I went to paramedic school, we had one of my instructors specifically took this class, and I'll tell you what, there's so much, there's actual career fields in law that are strictly for this. And that was something that he did before he started teaching. Was he went from EMS, being a paramedic, to being a lawyer, and he made it where that was his job in the law field, was to try to take care of EMS cases. So when you have to go to court, do you wear uniform or regular clothes? That would be, it really depends on why you're going. I would say default to your uniform. If it's for something that you were in the role of, like if you were in the role of your ambulance, yeah, I can't answer that one. That's actually, there's too many what ifs. That would be something to take up with your supervisor. Because if you're going and representing the ambulance company, they're probably going to want you in your uniform. If you're just representing yourself, then it's like, let's say they pulled you in as a subject matter expert, you can wear whatever. But if you're going there for something that is tied to your ambulance company or your fire department, they're probably going to want you to wear your uniform. Most cases are settled following the discovery phase, during a settlement phase, and don't even go to trial. So a lot of times, like if it's a malpractice issue and they can already just in the discovery phase see that it was a mistake, it won't even go to trial. They'll just go ahead, and your ambulance company or whatever your organization may just go ahead and write a check. For those that do go to trial, several types of damages may be awarded. You can get compensatory damages where you just basically have to pay. Punitive damages are intended to deter the defendant from repeating the behavior and are reserved for cases where the defendant has acted intentionally or with a reckless disregard for the safety of the public. The DUI driver, it's going to get punitive damages. At least, like there may be compensatory damages as well, but if nobody got hurt, who do you write the check to? So most likely that would be an example of somebody getting punitive damages. They're not commonly awarded in negligence. Usually negligence results in a fat check. In most cases, if a judgment is rendered against you, your service or its insurance carrier will pay the judgment. Sometimes, though, it does fall on you. It just depends on what happened. Again, that's one of those, there's way too many what ifs, so it's hard to tell. Any EMT charged with a criminal offense should secure the services of a highly experienced criminal attorney immediately. I would definitely not recommend being the guy that walks into the courtroom and says, I will represent myself. That usually doesn't end in your favor. All right, that is it. So give me just about 5 seconds to create your pin for the night and we'll get you guys going. I'm gonna do B. All right, your pin for tonight will be B as in Bravo, T as in Tango, C as in Charlie, 33. So let me type that into the group here so you guys can see it as well. And then we have BTC 33. So that's your pin for the night. So again, to log your attendance, bring up the ARES Med Solutions website. You're going to go to the courses menu, online training, online classroom, assuming that you don't still have the page up. And then that's going to bring you to the page that's got the green button for the live lecture, the blue button for the recordings, the Canvas link, and your attendance form is embedded in the page. So fill that out, put the BTC 33 for your pin for the night. That ties you to this class. And we will see you again on Tuesday. So y'all have a great night. Any questions on anything?